Good morning, afternoon, or evening. I'm very grateful to have the opportunity to present the optimization of safety surveillance of COVID-19 vaccines. So what is required for an adequate safety surveillance of COVID-19 vaccines, which of course is crucial? So on the left-hand side, what we see, we have routine measures, which is done for every medicine that comes to the market. So first of all, data from clinical trials from the pre-licensure phase. And in COVID-19, these are, they are published actually in the risk management plans, which are also publicly available. But then we have an important routine measure, which is spontaneous reporting. And this is done through spontaneous reporting databases, which exist in the US, such as the VAERS database, in Europe, the Eurovigilance database, and then there's also a global database, VG-based, that is actually a WHO-led initiative. On the right-hand side, we see additional monitoring opportunities, and these are actually being put in place for the COVID-19. And that is to do active surveillance of for signal detection, to do a rapid assessment and to have signal evaluation capacity. So today we will look at all of these actually in more detail. So on this slide, we see actually the program for safety surveillance of the COVID-19 vaccine. So in the arrow you see above the start of the vaccination, so that's the licensure of the vaccine. And on the left-hand side of that, we see a box which is in red, and these are actually the activities that could be done prior to licensure. So first of all, the trial data, which we have all seen, but other activities that were conducted were actually to prepare a list of adverse events of special interest, ASI, and these are events that not necessarily occur after vaccination, but for which you want to be prepared, that if they occur, they would actually be able to derail a vaccination campaign. So you do want to have the definitions ready, and you do want to know how often these events occur in the absence of the vaccine, so that you're able to calculate immediately whether they occur more frequently once the vaccine is on the market. And we'll look at that. Now, after the start of the vaccination campaign, what needs to be put in place immediately is the spontaneous reporting. And what has been put in place specifically for the COVID-19 vaccines is the cohort event monitoring. Then later on, once data is starting to accumulate in the healthcare system, you also want to utilize large linked healthcare data, which are actually collected just for healthcare purposes, but can be reutilized to monitor safety. And you want to start using those data sources also to complement signal detection, but also to be able to do a rapid assessment of the incidence rates following vaccinations and to conduct signal evaluation. Now, how was this prepared in Europe? And of course, we also have programs in other parts of the world, but I saw that my CDC colleague will be talking about this in more detail, so I'm focusing on Europe. So EMA makes all the trial data available in the risk management plan, which is actually usually is not publicly available, but now is publicly available, so anyone can find that. And it funded a project, the Access Project, which created a list of ASI. It created the definitions for those, as well as the background rates. And we'll look at some examples later on. What EMA has also in place, and that's part of their existing capacity, is the Eurovigilance system. And it funded particularly or for COVID-19, the early COVID vaccine monitor project, which is conducting cohort event monitoring and the monitoring through large linked data sources. If needed and the system needs to be scaled up, there is also the European Network of Centers for Pharmacoepidemiology and Pharmacovigilance, which can support signal evaluation if needed. And the European Medicines Agency does this through tendering of specific projects according to European rules. Now let's look a little bit more detail to this Access project. What it did, it actually listed 27 ASIs. We'll look at that in a later slide. it prepared all the codes that you can that you need to identify those events across different vocabularies such as ICD-9 and 10, READ, ICPC, and it had the definitions. And this was already delivered in September 2020. The project also created 8 template protocols to assess coverage, effectiveness, and safety of the COVID-19 vaccines. And it used different types of data collection, and these protocols are ready to be implemented if needed, so that all the scientific discussions around them and the stakeholder input on them has already happened, and they are just ready to go if it's needed. Then what the Access project also did already prior to the is to create the background rates of the ASI, and we'll look at an example later. In this slide, you see an overview of the adverse events of special interest that have been defined. So a long list of events that some of which we know may occur after other vaccines, so they are listed here. Narcolepsy, because one of the upcoming vaccines may have the adjuvant ASO3, which has been associated with narcolepsy in the H1N1 pandemic. And then death, sudden death, and COVID-19, and death was added, is on this list because it's clearly able to derail a vaccination campaign if that would happen. So you need to be ready to know that. And then in the project, the Access project, there were also maternal neonatal outcomes for which you want to be ready if pregnant women will be vaccinated. You also want to know, whether events occur. So what is being done for each of these ASIs in the Access project is that actually the background rates are being calculated, and a background rate is an incidence of an event. So how often does an event occur in the absence of the vaccine? And this, of course, could very nicely be done prior to the launch. So this has been calculated on the basis of various data sources in Europe in 7 countries. Utilizing existing healthcare data. And what you see here is a graphic where on the x-axis you see the incidence rate per 100,000. And this is the event death. So this was done for each of the other ASI, but now we look at death. And here you see per database. So ARS here is a database in Tuscany, and you see the death rates by age. And you see very nicely in this graphic that the incidence of death really increases with increasing age, as we expected. And this is a similar pattern across all of the countries, of course. But here we have the exact number. So how often, what is the exact mortality rate in that specific age category? Now, it's very important to know that because, for example, there was a signal very rapidly after the start of vaccination in Norway, where 23 deaths were reported in frail elderly. And this caused quite a concern initially. But then, because the Norwegians could rapidly estimate that these old people in these nursing homes, on average, they would expect 300 to 400 patients to die in these facilities. The 23 was much less than the 300 to 400 you would actually expect. So basically, the background rate, which is the mortality rate, was being utilized to calculate how many patients you would actually expect to die. And especially once you start vaccinating very old people that have multiple morbidities and have higher rates of certain events, it's important that you can put the events into a context so that you know what you would expect, so that you can always rapidly assess whether the observed is more than the expected. So because of these calculations, the Norwegian regulators were able to reassure the public. And it was necessary according to their lessons learned, and this is a screenshot from a presentation they made to the WHO Euro meeting, to really, because very quickly this signal was out in the media, and they needed to really quickly respond and work together also with international organizations to get this message out. So that's how to do, if there is a signal from spontaneous monitoring, how you can utilize the background rates to actually interpret them. Now here we look at the next step, that's the cohort event monitoring, which has been put in place specifically also for the COVID-19 vaccines. It's active surveillance, so you really want people to actively report, and the way this is being undertaken is that people that are vaccinated are invited to participate in this cohort event monitoring. They can register online, fill out a baseline questionnaire, they get their vaccine, and then periodically, after 1 week, 3 weeks, 6 weeks, 8 weeks, and 3 months, they get a questionnaire that they can fill out. And the purpose here is to monitor the occurrence of adverse events. So you can actually calculate how frequently they occur. Such a system is being put in place, was put in place in the US, and that's the vSafe system. It's being put in place in Germany. The SafeVac system is being put in place in the Netherlands and other countries as part of the early COVID vaccine monitor project. So they're all monitoring the occurrence of the of adverse events following COVID-19 vaccination. What can you expect from such a system? And this is data that was presented by Tom Shimakaburo from the USA CDC. Basically, you can count for each of the vaccines. Here is Pfizer BioNTech dose 1, dose 2, Moderna dose 1, the frequency of local and systemic reactions in the first week. And so you see here that reactogenicity or reactogenic reactions, the local reactions and more systemic reactions that we were expecting based on the clinical trial data, do occur also, in real life, very frequently actually. So pain, dose 1, 67%, 74% after dose 2. Moderna dose 1, very similar to the Pfizer vaccine dose 1. So quite, we can see that the vaccine is reactogenic, that the system works, it's picking up these events actually. And so this is how safety can be monitored using these active surveillance systems. So basically a cohort of vaccinated people is being followed to monitor systematically what is happening. So all these systems that I was talking about, so the spontaneous reporting systems, the cohort event monitoring systems, have been put in place by regulators or public health organizations in many parts of the world. But there's also the need for vaccine manufacturers to do additional monitoring studies, and the ones that they are planning, you can actually see in the risk management plans. They show all the planned studies. And this is just a screenshot from the Moderna risk management plan that's listed on the EMA website. So as part of their activities, they are also stating they will do post-authorization studies in the US, looking at active surveillance of signal refinement and self-controlled risk interval studies. They have planned a similar study in the EU, so to conduct post-authorization safety surveillance studies using secondary health data to monitor real-world safety of their vaccine. Now, it's not just Moderna that needs to do it. Each of the manufacturers will get the requirement to do additional studies to address questions that are still there, or identified risk or potential risk that have been identified upon authorization. How can this be done? So here we look at an overview of how distributed analytics have been set up utilizing electronic healthcare data. So in many organizations have access to electronic healthcare data that is population-based. So this is an overview of the Sentinel system that is running already more than 10 years. So there are different data partners. And here it's a graphic of 17 data partners across the US. They put their data into a common data model, so it's the same structure of the data. Then there is an operating center that can send a script to the data partners. They run it and they return the results to the operation center that can then pull it and send it to FDA or to anybody who has contracted with them. A similar system, different scheme in Europe through the vaccine monitoring collaboration for Europe. All type of different data sources that reside in different places can participate across different countries. The data stay local. They just are being reformatted into a same structure. Then there is a step of semantic harmonization. A script is being launched, so the analysis done, and then the results of that analysis is being shared on a remote environment where data can be pulled. So all of these systems are operational. They are existing also for the Vaccine Safety Data Link, for the BEST initiative in the USA, in C-Notes in Canada, and in Europe, and they can be used, these infrastructures can be used both for public as well as privately funded research. Then what is needed for the analysis of such large linked databases, of course, protocols and methods readiness. In Europe, these template protocols are ready, as I explained before. It's important, that protocols for each of such designs is ready, and depending on the type of event that is coming up as a safety concern, you would need to choose the right design, but the template protocols are ready to implement those. So what we see in terms of readiness, at least in the higher income settings, is that there is data readiness, both in terms of passive surveillance, active surveillance through cohort event monitoring, but also large linked databases that are ready. People are ready actually to work with each of those data, and the methods have been defined and gone through stakeholder input. So all of that is ready, but we know from the H1N1 pandemic, when we were also ready to look at certain events, but then that narcolepsy popped up as an unexpected safety concern. And what really was important at that moment in time is that there was collaboration, and not just national collaboration, but also very much international collaboration. So as part of that preparedness, the vaccine monitoring collaboration for Europe was being set up. So an organization that allows collaboration across multiple independent organizations in Europe to address vaccine studies, post-marketing. And the same is done also for the Global Vaccine Data Network, which is doing this distributed analytics on the basis of data on a global level. So utilizing both Sentinel, VSD, VAC4U data, and then other continents as well. It's very important to have this readiness and to be able to work together and to respond very rapidly when safety concerns occur. Thank you very much.